Good afternoon. This is Dr. Wynndel Buenger with Interventional Pain Consultants. One of the common problems that we at IPC deal with today is patients who have been on chronic opioid therapy for benign pain. This is not the patient who takes chronic opioid medicines, such as morphine, for cancer. This is not a discussion regarding cancer pain. Patients who have chronic benign opioid therapy many times have been treated for many years. These patients feel that they have done very well and been very successful because they're familiar with their own treatment. However, studies have not been developed that show that patients do well over a great period of time with chronic opioid therapy. In fact, several things have come up recently which have changed prescribing habits. The opioid epidemic that unfortunately we're all too aware of, and many of us have lost family members or friends to this problem. The CDC published a position piece that has stated very clearly that there are guidelines and rules for chronic opioid therapy in the benign pain patient. These CDC guidelines initially addressed primarily family practice and internal medicine physicians, but now are felt to be appropriate for all providers. The FDA has come out with guidelines regarding what combinations of medications can be administered safely. It turns out in many studies that the combinations of benzodiazepines with opioid medicines, such as morphine or hydromorphone or oxycodone, have a 4 to 10 times increased risk of death, and hence these medications are not to be co-administered. At Interventional Pain Consultants, our goal is not to treat your anxiety, our goal is to treat your chronic pain. We try to work with our psychiatric colleagues to find the best treatment plan for your anxiety under the care of your psychiatrist that minimizes your risk. We then try to treat your pain under the guidelines to further minimize your risk. Thus, someone does not require a combination of opioid therapy and benzodiazepine therapy. The Federation of State Medical Boards has been the guideline that pain clinics and providers who use opioid medicines have long followed. That basically tells doctors what is expected at a doctor's office visit. When a patient comes in, you're required to do a history, you're required to do a physical, you're required frequently to do urine drug screens. You should do appropriate psychiatric screening for problems such as depression and anxiety. You need to do a review of systems. You need to do a full health analysis. You have to have a clear understanding of why someone might be having severe chronic pain, and you have to determine the best course treatment. Does that or does that not include a potentially addictive medicine? The CDC study points out the Veterans Administration study, which shows that patients who are taking less than 20 milligram equivalents, all opioids are converted into morphine, so we can easily discuss it. Whether you're on hydromorphone, oxycodone, oxymorphone, fentanyl, it doesn't matter. We convert them all to morphine for simple discussion. Otherwise, it would become very cumbersome and complicated. Patients who are on less than 20 milligrams of morphine a day do not have a significant increased risk of death. However, the risk of death increases when you go above 20 and is increased up to 50 milligrams of morphine. Then again above 50, when it goes up to 90, we see another increased risk. And then above 90 milligrams of morphine, we see again more increased risk. We consider high-dose opioid therapy to be above 90 milligrams of morphine a day. We very strongly try to avoid high-dose opioid therapy in patients who have chronic benign pain. Once again, it's so important to understand that this is not a discussion of someone with an acute broken bone. This is not a discussion about an acute surgical patient who's just had an abdominal surgery. And this is very clearly not a discussion about patients with chronic, incapacitating, potentially soon to be, unfortunately, fatal cancer. This is simply a chronic benign pain problem that could be from degenerative knees, that could be from a bad neck, that could be from a low back. We're talking simply about trying to minimize risk and maintain functionality in these chronic patients. At Interventional Pain Consultants, our goal is always to give you the best quality of life while minimizing your risk. Thank you very much and have a great day.